Welcome to the Metabolic Link, a medical and science-focused podcast that explores the common thread of metabolism in health and disease. This is where science meets society. Welcome back to another episode of the Metabolic Link. I'm your host, Victoria Field, and I am very excited to be sharing today's interview with you. I had the absolute privilege of interviewing Dr. Deanna Kelly. Now, Dr. Kelly is a professor of psychiatry at the University of Maryland School of Medicine. She serves as director and acting director of the treatment research program at the Maryland Psychiatric Research Center, and she has over 25 years of experience in psychopharmacology research. She's authored numerous books and articles focusing on schizophrenia and severe mental illness. Dr. Kelly was actually leading a groundbreaking trial investigating the use of the ketogenic diet for schizophrenia. In fact, this trial was the only inpatient study looking at ketogenic metabolic therapy for serious mental illness in the United States. However, the trial, which was privately funded, was unfortunately recently shut down by the Maryland Department of Health. This interview was actually recorded ahead of this recent news. Just want to mention that as you listen to the episode. I also want to mention that we have linked a petition that was put together by Dr. Christopher Palmer. You are probably quite familiar with him and his work. He's been on our podcast before and at Metabolic Health Summit. He's a Harvard psychiatrist, and he put this petition together on change.org that urges Maryland's health secretary to reconsider her decision. Now, if you agree with this, if you agree with the petition, please consider signing it. In the meantime, we hope you enjoyed this episode and the incredible work of Dr. Kelly. Thanks so much for watching. Hi, Dr. Kelly. Thank you so much for joining me today. It's such a pleasure to have you on the podcast.
Yeah, thanks so much for having me. I'm glad to be here today.
Really excited to dive into your work. You've been doing this for well over 25 years in psychopharmacology research specifically. Let's kind of take it back to the beginning, where you sort of started. What really sparked your interest in this field, and how has your passion evolved to include now metabolic-based therapy over time, over the years?
Sure. So I've been at the University of Maryland at the Maryland Psychiatric Research Center for a little over 26 years now. My schooling and my education was in the area of pharmacy. So I received my Pharm.D and went into the field of psychiatric pharmacy practice and really got right into research. And so I've been at the Maryland Psychiatric Research Center, and there we treat primarily people with severe mental illness and who have schizophrenia. And so we're a center that combines treatment and research together, which makes a nice place to ask questions, answer questions, and better treat our patients. And so really my field and my line of research has been in trying to find new treatments for people who have severe mental illness and schizophrenia. And in the early years, we tested a lot of early years, meaning in the beginning of my career, we tested a lot of new antipsychotics. One of the main treatments for those who have psychosis or schizophrenia-like disorders. We tested a lot of different strategies, both pharmacologic and otherwise. And in more recent years, I've been drawn to finding and understanding how inflammation, oxidative stress, and other pathways like glucose metabolism might be dysregulated or out of function in people who have schizophrenia. So what's interesting is that if you would have asked me 15 to 20 years ago if I would have been in this area of the field, I would have not believed so, but science took us there. And so really we made it here through science and sort of understanding and these small discoveries of what really started in the inflammatory world. And so I had found initially that there were certain groups of people with schizophrenia who had antibodies to or immune responses, for example, antibodies to gluten. Or gliadin, which is a protein found in barley, wheat, and rye. And this subgroup of people who had schizophrenia and had these gliadin antibodies, I was able to show in a clinical trial that we can improve some of the psychiatric symptoms of their illness with taking away gluten in this subgroup of people. And so it really got me thinking how much of an impact that diet can play in mental health. And in fact, the results of our study are as robust as some of the best treatments that we have. And so that's really fascinating. And so in that space, I've been able to extend our work, and we're trying to understand why that might work, why it happened, why it might work, so that we can actually create new targets in the future. And then more recently, is still completing some of our work with the gluten-free diets. We started to become really interested in metabolic processes. Especially, we had developed and better understood oxidative stress in the body. And so myself, along with a group from College Park, Maryland, engineers, et cetera, we developed a way to measure oxidative capacity in the blood, which is really fascinating. And so we've been able to show differences between this oxidative stress measure in people with schizophrenia versus healthy controls. And we've been able to show that we can measure changes in oxidative stress in different ways, and hopefully be able to relate that to changes in the brain as well. And because I started to understand oxidative stress better, and we were targeting oxidative stress through a couple of clinical trials that we have going on. We have a clinical trial looking at luteolin, which is a compound found in vegetables in very high doses. We're looking at its potential for improving oxidative stress. But we also have started to understand the gut microbiome and its relationship to all of these processes I'm talking about. So we're doing work with prebiotics, being able to feed some certain bacteria to produce short-chain fatty acids in the body to improve cognitive function or improve function through that mechanism. And all of that has then led to the idea that a ketogenic diet could be important for people with severe mental illness. And there's a whole line of research over time that people may not be aware of. But really, there's a paper in the 1960s that came out in a small, I think, state hospital in Louisiana, and it was showing us that in 10 people given a ketogenic diet, they did extremely well in this setting. Now, that was a long time ago. And so since then, there's been just a small amount of work. Diets and these kind of things fell out of favor for quite some time. But now that science is bringing us back, there's been more recent studies showing that in animal models, ketogenic diet could prevent schizophrenia-like symptoms if we try to induce them. And that's fascinating. And then there was a couple of papers that came out, one from a group in France, where they looked at ketogenic diet in a retrospective design. I mean, they looked at research records and clinical records in 30-some people. And I think there were 10 people who had schizophrenia, and they had shown that their symptoms were dramatically decreased after a ketogenic diet, such so that their mean scores, like on a rating scale, on average, a score was 90 in the 90s and decreased to like in the 40s. So almost cutting in half their symptoms with a 40% decrease. And then there was, I think, a couple of other case reports, several case reports in our literature. But then even as early as or late as last week or a couple weeks ago, there was an article published both in bipolar patients and schizophrenia patients with a small sample of schizophrenia patients. And this had gained a lot of attention because it's very exciting. But in the 5 schizophrenia patients, I believe that there was, I think, about a 30% decrease in symptoms. And so all of this history and all of this story has brought us to where we are today.
Which is a really exciting place. And thank you for sharing all of that. I mean, from where you started to the things you've discovered along the way, in terms of looking at inflammation and that leading to taking a look at gluten, and then that evolving into, developing something to look at oxidative stress, and then on to, the ketosis. It's really a fascinating journey that you've taken. That I'm sure now, kind of looking at where you're headed. I mean, I feel like metabolic psychiatry and that entire field is such an exciting place to be. Really, you're leading the charge in potentially changing the face of mental health care as we know it in the work that you're doing. So I want to take a quick break to say a special thank you to Genova Connect, who is a sponsor of this episode. Genova Connect, which is powered by Genova Diagnostics, offers simple at-home advanced lab testing that's really taking the guesswork out of understanding your health. What I love the most about this company is they're grounded in research. They're not just a lab, they're really innovators in health and wellness. Whether it's gut health, hormonal balance, nutritional insights, their tests provide it all and really give clarity and direction so you can optimize your metabolic health, because that's at the end of the day what we're all trying to do, right? I've actually personally used their gut health test and their Metabolomics Plus test, and both, I was just blown away by the data that you get from these tests. And not only that, but you also get actionable things that you can do, different descriptions of whether it be, supplementation, food, or what have you, that might help in the process of working with your physician to rebalance or recalibrate things if something might be off. So they give you such just valuable information beyond just, your numbers, right? Where you fit within, the spectrum of results, and you actually can do something about it with the tools that they provide. I'm really excited to share that Genova Connect is offering you 15% off any of their test kits when you use the code Metabolic Link at gdx.net/the-metabolic-link. That's the code Metabolic Link without the at gdx.net/the-metabolic-link. So make sure you throw in the when you go and search online. And I really think you will not be disappointed if you try one of their tests and give it a try. Now back to our episode with Dr. Kelly. Thank you for sharing that. And it's very exciting. It's very exciting, even though we're kind of, it's sort of in its infancy in terms of, well, it's funny because as you mentioned, the diet back in the 1960s, I think you said, was used in a study then, but then since then, there's not been very much that's happened. So there's much work to be done for sure. And you're actually leading the charge in a trial as we speak.
Right.
Titled Single Blind Randomized Ketogenic Diet versus Control Diet in People with Schizophrenia. Would love to share more about what you can in terms of, that study design and what you've seen so far, as much as you're able to share with us today.
Yeah, no, this is exciting because I work in this setting where we have a public university partnership with our state system. And so we have a research program embedded within our state system, and we're able to run inpatient studies in a collaborative fashion. And so this allows us to then have a study, a somewhat challenging study like a ketogenic diet study. Implementing that in care is really, it could be challenging for people. It's new. It's a new way to think about ratios of food, of giving so much fats to carbohydrates, and it could be overwhelming. So in our design, we're able to do it in the hospital, which is really, it's the only one in the United States that's inpatient. And I'm really kind of proud of that. Like, we're proud of that.
You should be proud of that. That's amazing. And that means a lot for being able to do great research that's very controlled. And anyway, continue.
Absolutely. No, absolutely. And so our dietary works together with our nutritionists. We have consultants from Johns Hopkins and the University of Maryland. So really it's a collaborative team effort, and the state, we're a team effort. And so we're able to design the study that's inpatient. And so what we're doing is we're doing what you call a single blind study. And it allows us to, and it's randomized. So when people sign up, they consent for the study, they're involved in they decide they want to be in the study, and they qualify for the study. We have inclusion and exclusion criteria. That means they're either randomized to a ketogenic diet or a diet is treatment as usual. But it's randomized in a fashion that no one knows what you're going to get. And then it's single blind, meaning that we have raters, or these are clinicians who are expertly trained in how to test and measure symptoms of patients. And they are blinded. They don't know what any of our people are taking, if they're taking or if they're eating a ketogenic diet or a regular diet. And so then they're able to rate their symptoms in a blind fashion. So the benefits of this are of this kind of trial and are really quite good, because one, it's inpatient, so we're able to control a lot of things in the environment. So, and I'll come back to that in a minute why that's important. We're keep making sure that their diet is 100% adherent. We give them their food, we make sure they eat their food. If they don't eat something, then we can modify their next meal to make sure we stay in that ratio. And that's the benefit. But also, as I mentioned, the other studies that are out there, we have not had a randomized or single blind study in the field. And the gold standard for clinical trials really are these randomized designs. Double blind is really challenging because we're talking on a diet here. It's hard to give a diet that looks identical. So as of to date, this would be the best quality of study that we could design that would be out there and would really add to the case reports on all these open label studies. And if we could show in this randomized fashion, it really would give a lot of scientific oomph behind this in these patients. And going back to the idea that we're inpatient, a couple things that we're measuring stool samples. And so, yeah, an
You're looking into the gut.
Yeah, the gut to brain. And you might have heard about the gut to the brain. And we think that it's possible that a ketogenic diet might work partially because it modulates gut bacteria. And there's you could do a whole podcast on how gut bacteria can work with the brain. But the idea is that if we could modulate and possibly byproducts, et cetera, might actually contribute to interacting with neurotransmitters or direct pathways to the brain, we could change behavior that way. And so we're able in that setting, then we're able to have people donate their stool samples. We're able to control. And if you imagine the outside world, if people were doing that outpatient, a lot of things could interfere with that or confound it. So we're able to have a really clean, we can ask questions in a really clean way because we have things as most tightly controlled as we can. Exercise is pretty much, everyone exercises about the same. Activity levels are about the same. So we're giving it the best shot that we could give as having this inpatient design. And so that's the basis of what we're doing for the clinical trial.
That's really, really exciting because as you mentioned, there's not many sites that can actually do this inpatient where you've got so much control over, how things go, because when you're talking about food and diet, it's really challenging. One of the biggest challenges I would say obviously with the ketogenic diet and looking at it in this way is, people are living their lives outside. It's very hard to control for in many different ways. At one point I was with a nonprofit and we were implementing the ketogenic diet with cancer patients. And, but, they weren't inpatient, they were living their lives. And it's very challenging. Granted, we measured blood glucose and ketone levels and we could kind of track and would get notified when they would pop out of ketosis and things like that, which is helpful. But you mentioning how if they were off one meal, didn't eat the entirety of the meal, that the next meal you could adjust for macronutrient ratios and things like that is a level of specificity that I think is just going to open up so many, eyes to what this actually means. And I think it's going to really be exciting to take a look at the research. Yeah, go ahead.
Yeah, and as you said, so we're also able to monitor and make sure they are in ketosis on a regular basis. So you can imagine the outpatient, you can't really check that every day, or maybe you can, but it's a little bit more challenging. But we do check it every day by a few different ways. We're doing finger stick. So there's a thing called a keto mojo. And so we're able to look at the beta hydroxybutyrate levels by a finger stick. We do that twice daily, actually. And then we also do a breath ketone measurement as well as urine. And so we're going to be able to see what might be some of the most effective ways to monitor as well, so that when we do start to implement this in outpatient better, we might be able to have data that helps the rest of the field, helps all of us together understand, can we just use urine? Can we use blood? Can we, how do we best measure ketosis to make sure people are in ketosis? So we're able to have additional monitoring that will help the field, help us all in general.
It's such an important study and work that you're doing. So really, really exciting. Thank you for sharing all of that.
Of course.
What have you seen so far? What do we know so far? And in your experience, what have we seen so far in terms of metabolic dysfunction and its relationship with schizophrenia, things like insulin resistance? There's so much exciting emerging research, but what do we really know so far about the relationship between these things and inflammation? I'm sure you've seen a lot along the way in doing the research with gluten and what have you. Would love to hear your thoughts around where do we stand right now?
Yeah, no, this is a really good question. We don't know the answers to this, but traditionally we have thought that really simplistically that schizophrenia is an imbalance between neurotransmitters in the brain, dopamine and serotonin. And that's where the field really had been. And most of the treatments that are out there were treatments designed to block dopamine, just to do that. And so all of our antipsychotics, most of them, almost all of them will block dopamine, and that has side effects associated with it. And not everybody receives treatment from that. So, or not receives benefit from that. And so we've been on a quest for quite some time to figure out, what really might be the underlying cause of schizophrenia, because that's not necessarily, that might be part of it, but that might not be all of it. But things we've learned over time is that we do know that there appears to be glucose dysregulation in people with schizophrenia. And so even before they ever receive antipsychotic treatment, when they're treatment, we call them treatment naive, when people have not even been treated with medications or other things that might have interfered or, made their metabolic symptoms worse, we see high levels of metabolic dysfunction, insulin resistance, hyperglycemia, which are high glucose levels. And that leads us to think that something might be going on besides, just this dopamine imbalance. Something else is leading to contributing, and that's just some of the evidence. There's other evidence from imaging studies, for example, that there is glucose dysregulation and differences happening in the brain. Actually,
Dr. Stephen Kinnane's work, right?
Right. Yeah, absolutely. Like bioenergetic function is different. And so there's a lot to learn yet. And so we don't know exactly, what might be causing schizophrenia or a lot of other mental health disorders for that measure, or for that example. But we do have a lot of information that this is a really strong piece of the story. And so I'm excited by the fact. I mean, we all know about some of the epileptics studies from 100 years now. These children do really well, and that's fascinating. And I think that's kind of led us into this area of the field as well. But part of my story is that I have a friend who has a daughter who had intractable seizures, had a genetic disorder called Ring20, which is a really rare chromosomal disorder. But the only thing that helped her was a ketogenic diet. And her parents would say she wouldn't be here today had she not been on a ketogenic diet. And, there's different parts of our stories that bring everything together. And it was fascinating for me about a decade ago to kind of go through that and walk through that with her and to understand, wow, how does the brain actually, in the infancy stages of ketogenic diet, how does this actually contribute? So it's been a piece of my story too, is to understanding, and now that it's coming full circle where I'm actually running a ketogenic diet study is really kind of fascinating to me, and that kind of comes full circle.
I want to take a quick pause to say a special thank you to Fatty15, who is a sponsor of this episode. I'm really excited to actually be sharing this incredible scientific breakthrough with you that supports our long-term health and wellness. It's called C15, and it's the first essential fatty acid to be discovered in 90 years. And get this, studies actually show that it's 3 times better, broader, and safer than omega-3, which is really exciting. It's pretty simple. Essential nutrients keep our cells healthy, which makes us healthy. Studies show that C15 works by strengthening our cells, improving our mitochondrial function, and protecting us against damaging free radicals. And the result is better long-term metabolic, liver, and heart health, which is what we're all after. Highly suggest you check out this product. Fatty15 is really on a mission to replenish your C15 levels, restoring your long-term health, which is what we're all trying to do. And you can get an additional 15% off their 90-day subscription starter kit by going to fatty15.com/metabolic link and using the code metabolic link at checkout. That's 15% off their 90-day subscription starter kit by going to fatty15.com/metabolic link. Use the code metabolic link for the discount. And I know you're going to enjoy the product, and let's kick off the rest of this interview. Yeah, that's pretty incredible. You got that personal experience, and that, she experienced such great success with it. It's fascinating. That's even some families dealing with epilepsy go on a ketogenic diet. And in some cases, they're on it for an extended period of time, and seizures don't come back even when they've gotten off of the diet,
right,
which is kind of wild and brings the question, is that maybe potentially something that could be an option for something like severe mental illness down the line? Of course, I'm sure it's very hard to say that at this point, but, you hear a variety of stories and through the case reports and whatnot that are out there right now where folks go on a ketogenic diet or dealing with something like bipolar disorder or schizophrenia or you name it, and experience their symptoms completely, go away,
Right.
and and as soon as they maybe hop back off of it, those symptoms start to come back. So do you
Right.
ever think this might be similar in that way, to where you have, granted, it may not be a large population of, portion of the population of folks dealing with severe mental illness, but in some cases, maybe we have a similar situation to epileptics, where some people are able to go on a ketogenic diet for an extended period of time, and maybe that repairs those issues in brain glucose metabolism, and they're able to,
Yeah.
come out on
That
the
would
other side
be
without it.
that would
Yeah, I
be
don't
that
want
would
to
be
say cure,
amazing.
but
That would be
yeah.
amazing. And it's not far-fetched to think that it's possible that if we could catch some of these underlying metabolic disturbances or reverse them before the illness onset, that we might be able to prevent. We're not there yet, but you could imagine that ongoing damage to the brain, continual problems happening, and leading to things like you said, treatment resistance. If we could catch that early, it would be really nice. So the field has a little way to go, but I would like us to be able to look at early on in the illness, what we call like first episode schizophrenia, or even in clinical high risk patients, eventually to be able to do a better job and see if we can predict who might benefit from this. And when we're looking for things to possibly intervene with early before the onset, it's really scary for parents to think, I want to put them on a medication even before they develop the illness to see if that prevents it. But something like a ketogenic diet doesn't have this medication side effects. So we could be at a place not too far off that we might be able to test it to see if we could actually prevent or mitigate early symptoms if we could heal the brain or change the way we do, the metabolism in the brain early on. And that would be such a benefit.
Oh my goodness,
Yeah.
that would change the mental health approach to mental health care as we know it, really. I mean, uh, in speaking on that same line, how do we know who might benefit from
Yeah.
this kind of intervention? What do we, in terms of what we know so far? I know you've got this sort of method for taking a look at oxidative stress, but how do we figure out who might benefit from personalized treatment in something, dealing with something like this?
Yeah, no, that's a good question. And personalized treatment is really important. I mean, we're really focused on that at our research center. I know others really are too. And if I think about it from like the gluten perspective, from my work in gluten, I'm able to identify a subgroup of people who have antibodies, and those are the people then that I expect to have benefit when I take that antigen gluten out of their diet. And so, in essence, we're finding a subgroup of people that would benefit the most. And we're looking at inflammatory signatures to see who might be those who are predictive of having a response. With the ketogenic diet, we're not quite there yet. So we haven't even established the gold standard double-blind studies yet. But I think we're moving in a nice parallel where we're looking at mechanism, we're looking at clinical trials. There's several clinical trials going on around the globe in bipolar disorder and other disorders as well. And we're hopefully now using a lot of biomarkers in our studies, like I mentioned, the gut bacteria. We're doing we're hoping to add into our study neuroimaging. We haven't done that yet, but we're hoping to do that. But other means to then be able to look at who might be predictive. And I think honestly, computational modeling, our field has really expanded. We work with a lot of people who use large amounts of data, and when you have large amounts of genetic data, large amounts of protein data, large amounts of bacteria composition data, it's too much just to do standard statistical analysis like we used to. But now we have to use large omics or data sets, and now we can use large computational models. And that's going to help us sort of see what are the pathways, what's the certain people that look like that might respond. So I don't think we're too far off for once we start to understand if this really works, which we think it does, who are the people that it works in, and then we can help our patients by then saying, like you said, personalized medicine, when they start, like it'd be nice to say, you know what, your chances of responding to a ketogenic diet based on these parameters and are really good. Like you have a 50 to 80% chance or 100% chance of responding. And that could be in the future where we come, like being able to like predict. I think it's really important. I think personalized medicine, and the right patient on the right treatment at the right time is really the way we need to be to go.
Absolutely. Yeah, absolutely. And how some of these nutritional interventions can work synergistically with current standard of care and maybe even improve the efficacy of some of the treatments that these folks are on. I think, yeah, I mean, the sky's the limit with this kind of approach to personalized care with especially when it comes to severe mental illness, because there's just, unfortunately, a lot of people are still struggling, even on some of the antipsychotic medications, as you mentioned, are still dealing with some symptoms. So this could mean a lot to a lot of people. Women's health issues is something, and schizophrenia specifically is something that you really champion, which is awesome. And I'd love for you to dive into some of the specific challenges and maybe considerations around treating women specifically in dealing with this severe mental condition.
Yeah, no, thanks for bringing that up. I love how the field now is embracing sort of women's health. But when I first got interested, 15 years ago, I felt like I was the only one really interested in women's health. We had the first clinical trial funded by NIMH that was specifically in females to look at
Right.
specific but that's sort of been our story over time. But I think there are some differences. Of course, women present differently. Women have a later age of onset. Women are not in the hospital as much as men are in the hospital. Their families take care of them in different ways. Women are subjected often to a lot more trauma. And all of these things play like epigenetic changes potentially that play into their course of illness, because trauma leads to different aspects of care that are difficult to treat,
Yeah.
worse symptoms sometimes, et cetera. But then the clinical trials, like our field really has just looked at everybody the same. And so most clinical trials that come to market, whether you're male or female, you get treated the same, because we haven't been able to have large enough studies that look at like, let's treat women only, or let's treat men only. But the field is starting to go that way. We do have some trials looking at like estrogen treatment, or specifically treatments for to prevent different side effects, because women have different side effect profiles than men.
Yeah.
And this is true not only for schizophrenia, but I think that paying attention to different aspects of care, this personally, you talked about personalized treatment, but are you a man or are you a woman, or like, how do you treat someone? Really, everything should be a variable in that equation, like to personalize that. So one of the studies we did, for example, is we looked at an adjunct study of adding adjunct low dose aripiprazole, which is an antipsychotic that has partial agonism properties for dopamine, not just the dopamine blocker, because a lot of women who have schizophrenia have high prolactin. So you give an antipsychotic and they can have these prolactin levels. And traditionally, no one has really paid attention to that over time, because they're worried about, let's just treat their symptoms, but not think about the whole person. And so now that we see that some antipsychotics cause high prolactin, that leads to a whole other host of issues. So if we can lower that, we can improve different aspects of their care, and not only hormonal symptoms or sexual dysfunction, but also potentially bone health and other outcomes. So we've been focused on that area for some time, but I really do have a passion of taking care of women with schizophrenia.
Yeah, it's really great. It's so needed because I mean, for as long as we have, just looking at the history of research as a whole across multiple different areas of medicine, women and just separating that out from men, it has been something that unfortunately doesn't happen often enough. So it's great that you're leading the charge and really standing up for women dealing with this really difficult condition. I want to take a quick pause to say a special thank you to Air Doctor, who's a sponsor of this episode. Americans take about 20,000 breaths a day and spend about 90% of their time indoors. The problem is that the indoor air we breathe, according to the EPA, can be up to more than 100 times more polluted than outdoor air, which is pretty gross when you think about it. So what's the solution? Well, Air Doctor. It's an air purifier that filters out 99.9% of dangerous contaminants so your lungs don't have to. This includes allergens, pollen, pet dander, mold spores, dust mites, and even bacteria and viruses. I personally have one of these units and I'm so impressed by it. It has this little light on the front of it that actually sort of like a sensor that tells you when your air quality is poor or it's okay or it's great. And when I'm cooking, it's wild to see how quickly that meter will fly to red and how quickly it takes this unit to clear out the room of, the harmful smoke or what have you. I swear I don't burn my food, but it pulls that out of the air. So my air quality is good again. I really think you should check these guys out. Head on over to airdoctorpro.com, use the code Metabolic Link to receive up to $300 off select air purifiers. Also exclusive to our podcast listeners, you'll get a free 3-year warranty off any unit, which is an additional $84 value. Lock this in by going to AIRDOCTORPRO.com and use the promo code Metabolic Link. And now back to our interview with Dr. Kelly. Speaking of, nutritional interventions with schizophrenia and some of the challenges just in general around implementing that, I can only imagine how difficult it is to, in some cases suddenly be diagnosed with something like schizophrenia. Or over time, this is, affecting a person. It's such a difficult thing to deal with, not just affecting that person, but typically the entire family dynamic and everybody in that person's circle. How does somebody go from, dealing with such a challenging, severe mental illness to implementing something like a nutritional therapy? I mean, it's even, you see this with cancer patients or anybody who deals with a very shocking and challenging diagnosis. To change your lifestyle can be one of the most difficult things without dealing with some of these conditions. So I'd love to hear your thoughts on how do we face some of those challenges and get through them and really, break down the barriers that I think a lot of people are seeing for patients dealing with this to maybe where they won't even bring it up to a patient, or maybe the patient doesn't even want to give it a try because it's seen as something too difficult. What would you
Yeah.
say to that? And how do we overcome those challenges?
Yeah, no, thanks for even bringing that up because we talk too often just about all these treatments and how good these treatments are or how we should try things. But when you take a step back and we're dealing with families for the first time who are diagnosed, who have a child or a family member diagnosed, it's not that simple to just to
Right.
jump into it all. And so really it's a process, and we really look at it as multidisciplinary and shared decision making, like trying to, you're because they're dealing with the trauma of just having this diagnosis or even the denial of having that diagnosis. But we do know that as soon as you get the earlier you get treatment, the better your long-term outcomes are.
Yeah.
So we really try to like work with people, and it's really not about um, spending a lot of time talking about the diagnosis, but
Mhm.
talking about like core symptoms, the things we're going to try to work on to get improved, to try to get things back, to try to get social function back and try to get school function back and try to, it's more than just like, I've got to treat schizophrenia. Like, it's really
Right.
about the whole person and what are going to be our goals and what are we going to aim for. We might not get to 100% on this, but let's like really aim to get to back to do this and this and this. And really, we talk about the dietary interventions, but we're not at a point yet to disregard all antipsychotic treatment and go right toward the dietary interventions. It would be nice if we were there, but really antipsychotic treatment is the mainstay.
Yeah.
I'm a big advocate for the medication clozapine, which we use as early as we can. We do have a really good results with that. There's a large, consortium across the country and the globe of people really trying to advocate to use that medication more frequently and sooner. There's a lot of barriers to care for that particular medication. A lot of doctors don't want to use it. And so at every aspect, at every piece in the care, we have barriers. And the
Yeah.
stigma of having the diagnosis or having schizophrenia is a barrier. And then getting these different treatments can be barriers. But I think that talking to people early on about, we want to treat the best we can. We're gonna use a combination of we're gonna use a combination of these medications that we think are gonna be able to help you do this and this, and like antipsychotics or whatever other agents we might need to do. Do they have depressive symptoms? Do they have anxiety? Like we treat other symptoms as well. But then I really do think this idea of giving people the option and understanding where diet can play a role early could be important too, because it empowers them and allows them to have a piece of their care and jump in and say, like, we can really manage this. Like we can try to do this. It's hard to get dietary like food and dietary interventions reimbursed through different
Yeah.
insurances, and that doesn't always happen. And our field needs to come, somewhere there. But we have to do better of having places where we can implement these kind of interventions, because I get people all the time that I've had a couple this week that said somebody with depression and somebody with family member with schizophrenia said, I would like to try a ketogenic diet. Where do I go? And, like I'm trying to connect them, but honestly, we've got to educate the field. We have to have providers out there that aren't just focused on one thing, but the whole health. And so all of us have to do a better job, but the implementation is going to be like, we don't want to get too far ahead of us with having all the science and then can't implement it. So we have to be working as a field, all the people that are working this space. How do we find out if the science is real, if this is really going to be, these are going to be, which we believe are so, but can we get these double blind, can we get these studies done, but then can we implement it and have that ready to be implemented? So I think we have some work to do, but we've got to be able to have places for people to be able to get care to help them, because it's not easy to start something like that on your own. You need a team of people to help you, nutritionists, et cetera.
Yeah, that's a great point. Yeah, it's this, all this research that's happening right now is so exciting, but if we can't implement it, it's really, where are we going here? And I think that's so critical. And having it's wild how limited resources there are when it comes to dietitians that can actually implement this specifically for severe mental illness. But that group is slowly growing, which is really exciting. And
It is.
I think there's going to be some barriers, though, I would say, in getting some of these practices or nutritional interventions into the wider medical community. I mean, what are your thoughts there in some of the things that we might face as, even as the science builds, what are some of those barriers that we're going to face down the line? How do we overcome that?
Yeah, I mean, insurance barriers, there's going to be time barriers, and there's
Big question.
education
Right.
barriers, all of these things. But there are ways to overcome it. And for example, there's a project that we did in the state of Maryland where we called it's a Project Echo, which is a standard format that came out of University of New Mexico, where the idea is to be a hub, and then there's spokes all around your state. So you can teach others how to do what you've learned to do. And so, for example, with clozapine use, we did a Project Echo. We called it Clozapine Champion Project in the state. And so we did bi-weekly, every other week, we did a standardized session where we did a small didactic, 12 to 15 minutes of just understanding this topic area, but then did some cases. So the clinicians from around the state, the psychiatrists, the nurse practitioners, the PAs, everybody that had signed up to be part of it could listen in and all talk about the cases, so that we weren't just disseminating knowledge. We were hoping to improve competence, because competence can change behavior. So these kind of like large initiatives where in Maryland we could implement it within our ecosystem possibly, and people in a case-based format. Okay, here's what someone looks like. How do we start the ketogenic diet? Like, what would we tell them? What would we tell the family members? It's nice to have actually family members on these calls. It's nice to have people living experience on the calls too. We learn so much. And so, for example, like, okay, we're going to start in the morning, and you're going to have scrambled eggs, butter, sausage, cream, macadamia nuts for breakfast. That's like the standard breakfast that we have in the morning on our unit. But then, like, how do we do that? How do we implement it? How do we cook it? What if you don't like this? Then what do you do? Like, there's just a lot of people that have to kind of, come together on that. But we can do education like that. I think there's ways, but I think there are that doing some work in like implementation science, which is a field of implementing and studying, can you do this and how do you do it best? I'd like to get there too. And I think our governing bodies are starting to fund in this area. I mean, traditionally, like our NIH has not funded, but they have funded our work in the gluten-free diet because it was very evidence-based. And I think if we do the same thing with keto, we should start to get more and more funding from our federal governments. But there are the funding agencies that are out there, private foundations have really stepped up to move things along. And that's really, I think, good for the field. And it's been amazing for our field to have people that are advocating.
Yeah, absolutely. I mean, it's critically important, right, to be able to move things along. What would you say? I mean, you've been through so much over time. I think over 19 clinical trials, I believe, completed, which is wild. What have been some of the most profound things you've seen over the course of that time? Maybe specifically related to nutrition, maybe not. But would love any sort of insights into what you've seen and some of the changes you've seen, maybe with the research you've done with gluten, or even as you're transitioning now into the ketogenic diet.
Yeah, so it's been a fun ride. Some clinical trials have just flat out failed and haven't shown anything, and you invest a lot of time, but that's important information too. That's important information. But there's some studies that have really made an impact on some patients, and For example, we did a study where we added minocycline, which is an antibiotic, onto their
Wow.
treatment regimen and looked at the treatment of cognitive symptoms and negative symptoms. And
Interesting.
in that clinical trial, we had a robust treatment response in a few patients. So I think we had a few patients who had 30 to 40, if not 50% improvement in some of their negative symptoms, but not
Wow.
everybody, a few people. And we actually, in that study, we had one person after 18 years of illness got well for the first time. Sort of some of the stories we're hearing with the ketogenic diet. So
Wow.
we thought that that medication has some anti-inflammatory properties.
Mm.
We thought that it had some direct effects on inhibiting microglial, which are sort of immune cells in the brain. And so there's been several other studies that have been done. It's not implemented as standard of care, but we often will use it in people that might be more catatonic or have some negative symptoms that are not treatment, or if we think there's an immune or inflammatory response and we see some benefit. So that was exciting to see a few patients really respond there.
Yeah.
We did some work with oxytocin. And so some of our initial work, we looked at oxytocin for improving social interactions
Oh,
with
interesting.
people. In our inpatient setting, we were able to show that we had a great improvement in negative symptoms, social interactions, if oxytocin was added. But in our outpatients, we didn't see as robust effect. And so
Mm.
sometimes that's a prime example of, the setting might make a difference because
Right.
we were using a nasal spray, and in the
Mm.
inpatient setting, we helped them do it. In the outpatient setting, they did it themselves. And so if we're not getting it, then you
Right.
can't get benefit from it. If you're not taking it, you can't get benefit from it. If you're not using the diet, you can't get benefit from it.
Right.
So
Right.
same thing, like in the inpatient, we're able to see sometimes see results. But obviously, and then in my gluten line of work, it's been good. And I'm really enjoying our work with the prebiotics.
Mm.
I really think what's been nice is we've been able to show we're focused on prebiotic treatment to improve short chain fatty acids. So things like butyrate, that's not to be confused with beta hydroxybutyrate, where we look on the
Mm.
ketone bodies, but they're not unsimilar. They're in the same pathway. But these short chain fatty acids improve cognitive function, improve some outcomes. And so we now have a large clinical trial. We've been able to show that we can improve butyrate levels by giving the prebiotic. What happens is we think the bacteria in the colon, that the butyrate producing species like this, they produce more byproduct, and then they can decrease inflammation in the body. We can improve things like oxidative stress, inflammatory. And so we're doing a replication study right now of the prebiotic. But I think there's going to be subgroups of that are going to benefit, and some people are going to benefit and some people are not.
Right.
It's the same, like if you don't have inflammation, if you don't have that as an underlying problem, if you don't have any oxidative stress, or if you don't have any of the systems that have gone wrong even on the glucose metabolism, if that's not your problem, you're not going to benefit. So I don't think everybody's going to benefit from everything, because schizophrenia is probably a syndrome of many different, everybody looks very different, but it's probably different subgroups of people that have similar symptoms. They meet criteria for schizophrenia, but there are probably some different underlying mechanisms that happen. So when we get to that point, we can sort of parse out a little better. There might be some people who are ketogenic diet is going to be their road to recovery, and others it might not be. So like, but the prebiotic work, the gut microbiome is we're really doing a lot in that space, and the gluten work's
Yeah.
been fun. And then the ketogenic diet I'm very excited about. So yeah.
Yeah, it's going to be really interesting to get some of the results from the work that you're doing now. I can't wait to hear what comes from that. In your opinion, though, some people in the field are talking about kind of peeling back the layers even further and looking at mitochondria specifically. I know you were saying for some people this might work, for others maybe not, because dependent on what's causing their
Right.
mental illness, right? It could be everything from there's trauma involved with many of these people's lives. There's gut microbiome issues, all of these things. In your opinion, though, where does dysfunctional mitochondria, where does that kind of play a role? Is that something that could be something that is sort of this underlying issue throughout
Yeah.
people dealing with mental illness, or maybe not for others? How do you see that?
Yeah, I think you've hit the nail on the head. I do think that mitochondrial dysfunction, as we really start to understand this more, is potentially plays a role. It's probably not it doesn't play a role in every single person. And so when we are looking at these studies, and when people are doing these mechanistic studies, they should pay attention to those who have what appear to have mitochondrial dysfunction and those who do not. Because if we treat everybody with a ketogenic diet and we start to not see a response or an effect, it might be because someone doesn't have underlying dysfunction of the mitochondria, or like problems with the bioenergetics. in
Right.
their brain. But we haven't got there yet, but I do think that that's going to be important. And I applaud all the people that are really studying some of these underlying mechanisms, like how our mitochondria work and how that relates to the symptoms and the disease states that we have. I think that's really important work, and we need to bidirectionally, as we find results in the clinical trials, and as people are finding results, even in the basic science or basic science side of things, continually feed this back and forth. So,
Yes,
yeah.
I agree 100%. And that's why we have a whole scientific conference, medical conference, Metabolic Health Summit that we put on specifically to bring all of these brilliant minds together to talk and discuss work, because I think that's one of the biggest things. Collaboration is one of the most critical pieces to the puzzle of all of this, right? Collaboration, and that way we can take some of the research that you're doing, but ensure that down the line it's actually being implemented in the real world, because that's got to be a big collaborative effort for sure.
Yeah.
I'd love to hear your thoughts in terms of, as metabolic therapy continues to evolve, what is your hope in terms of its future role with schizophrenia specifically? In all of your experience, where do you hope that this goes for us?
Yeah, so I would hope that we could implement these treatments much sooner in care. I would hope that we could eventually find that, maybe we could prevent, or maybe we could mitigate symptoms that are out there. I would hope that we would have a lot of providers being able to help people find this as a potential treatment, because not everybody wants to take medication. So if someday we could not have to take medication, or we're using other things, the modulating gut bacteria, where we don't have to take, medication, it might be taking food supplements, etc. But I would hope that we would move the needle sooner, because we're at a point still that we're waiting too long in care to provide good treatment, whether that's clozapine, or whether that's being able to introduce diet, or anything that's going to come down the pike. We're still waiting too long. And so as a field, we have to figure out how to move that closer to early care, to early intervention. So I really applaud like your metabolic mind, where you can have people, where you're really bringing recognition to this and bringing people together. So this just continually gets more people interested in the science, the research, and the clinical world follows suit. So
Yeah, absolutely. There's some really amazing groups that are just moving the needle. Metabolic Mind being one of them, and we're trying to do all we can. But the work that you're doing is so critically important to our understanding of schizophrenia, and how we better can treat people suffering from this, because unfortunately, there are so many people right now, I think, that don't really have many answers or places they can go. They've got maybe a condition that's treatment resistant. They've tried every antipsychotic or medication under the sun. That's just not worked for them. For people both on the patient side and the physician side that are maybe listening to this podcast, what would you suggest? Because it's so critically important for people who are dealing with something like severe mental illness to work with a provider, to work with somebody who knows what they're doing, to help them, if they want to try something like nutritional intervention. Because as you've mentioned before, it can have similar effects to pharmaceuticals. You've got to be really careful, right? So
right.
To the patient listening, or to the provider listening, just in terms of maybe the patient wanting to give something like this a try, or maybe the provider wanting to implement this with patients, what would you share with them in terms of places to go to be able to maybe get started, find more information? I know it's kind of slim pickings at the moment, but as you mentioned, Metabolic Mind are doing great work.
I actually
Education.
really appreciate
Yeah.
Metabolic Mind, because I'm recently just involved in their groups, and the
Right.
collaborations, and just being able to listen to some input and get even feedback, because none of us are, I mean, a lot of people are experts in their little space, but when we work together, we get the experience from each other. So that's been really important. I have actually been referring people to the resources on the Metabolic Mind
That's great.
website. And we've taught, and now that we have this community within Metabolic Mind, which I so much appreciate, we can send people at other places in the country and say, do you know someone here? Do you know someone here? We have, for example, at our research or in our university, we have an advanced depression center. And I was talking to them, like, let's start now. Since you're treatment resistant, let's start to think about implementing in treatment resistant depression. And so I think it's incremental, but telling, family members, people with lived experience, you connect with people, like read what you can, connect with people that you can find, and we're all as a field trying to help you all get connected. And so we'll do our best to try to help you find someone that could treat you. It's not, and there are some resources, but there's we'll continue to learn, and this will continue to grow, but we'll all help you as a field to get connected. So I think that's the important thing of this community, with what you're doing, with what Metabolic Mind and other groups are doing.
That's great. Yeah, it's great point. So I guess, where can people find you, your work? What would you like to share in terms of next steps for you? Because we'll all be following along as as you continue to do your research.
Yeah, no, thanks. So I'm at the Maryland Psychiatric Research Center. You can find me online, Deanna Kelly, University of Maryland. You can Google me. You can follow me on LinkedIn, or also I post a little bit on now X,
Oh, right.
Twitter a little bit, but I do post a little bit on LinkedIn. And so you can also follow me there and connect with me there. But I do, honestly, if you talk to most people in the field, if people reach out to me, I do get people, family members that contact, and honestly, I try to field them. I do my best, and
Wow.
I have a team of psychiatrists at the hospital, and others that we do try to take, and everyone will speak to this. We do try to take a Zoom call, or we'll try to take a phone call and see if we can connect you. So if you don't reach me on the first email, because our emails at the university are publicly available, not all universities are, they are publicly
Right.
available. And so we are public servants out there. So yeah, email us and we will connect you to someone else if we can't help you. And I think, working where we're at and what we're doing, I'm hoping that we can help as many people as we can. But we have a lot of fun other studies going on, a lot of important science. So
Yeah.
you can continue to follow our work, and hopefully you'll continue to see the work in this space be published. So.
Well, thank you so much for all the work that you've been doing well over 25 years now. It's something that we deeply appreciate. We'll continue to be following along with your work as well, and be sure to share it with everybody. And yeah, thank you again for joining me today. It's been such a fun discussion. I'm sure I could talk to you for another hour about this information, but I know you're a busy lady. So thank you so much, Dr. Kelly. Really appreciate your time today.
Oh, my pleasure. Thanks so much. I love the conversation. Thanks again.
Yeah, thank you. All right. And thank you guys for watching. Until next time, we'll see you soon. Thanks for listening to this episode of the Metabolic Link. If you enjoyed it, please give us a review on any of the major platforms that you might be listening to it on. It really helps us continue to get into more eyes and ears, and ultimately spread metabolic health and therapy research as far as we can. You can also subscribe to us on YouTube if you happen to be watching it there. Please leave us a comment. Let us know what you think. The more feedback we can get, the more we can provide you with episodes that you enjoy. And again, please consider signing that petition that Dr. Christopher Palmer put together to encourage Maryland's health secretary to allow for this important trial led by Dr. Kelly to continue. As always, thanks so much for tuning in.
Do you love learning about metabolic health? So do we. It's why we created the Metabolic Initiative, an online educational platform providing evidence-based education on metabolic health and therapies for healthcare professionals and the general public. By joining the Metabolic Initiative, you'll gain access to hundreds of expert lectures, interviews, panel discussions, and even private episodes of the Metabolic Link. CMEs are available. Go to metabolicinitiative.com to get started. And as always, thank you for listening to the Metabolic Link.